Hello, my name is Maxim Itkin. I'm a professor of radiology and pediatrics at the University of Pennsylvania Perelman School of Medicine in Philadelphia, and I joined by my colleague Gregory Nadolski, who is an associate professor of radiology and co-director of Penn Imaging Guided Intervention Lab here in Philadelphia. It's part of the Department of Radiology and Interventional Radiology. So Dr. Nadolski has a long-standing interest in the lymphatic interventions for the last 10 years. And today we'll discuss the current and future application of use of ethiodized oil in lymphography and why the ethiodized oil is important for lymphography. First, can you tell us a few words about the history? Why are we actually using ethiodized oil for lymphography?
Sure, Dr. Itkin. Glad to be here with you. So the history, I guess, of thiodized oil for lymphangiography essentially is that as an oil-based contrast, it basically is retained within the lymphatic system and doesn't leak out of the lymphatics. Historically, this started with doing pedal lymphangiography, where small lymphatics in the feet were accessed with small 30-gauge needles and connected to the lymphatic pumps, which had thiodized oil infused through them at a slow rate, allowing images of the lymphatics of the extremities all the way up to the inguinal region and even eventually into the abdomen and pelvis. More recently, and back maybe I guess it's been about 12, 13 years, we started doing this through needles placed in the inguinal region under ultrasound guidance and adapting that technology and technique to infuse thiodized oil into the lymph nodes, bypassing the legs and starting to intervene and image the pelvic and abdominal lymphatics much sooner.
Very good. So, and can I, you just mentioned 12 years. So what kind of new imaging techniques that using ethiodized oil or other contrast agents been developed recently?
Well, specifically, I think to the thiodized oil, we like I said, we adapted that technique for ultrasound guided access to inguinal lymph nodes. We also have found ways to access lymph nodes that have been opacified in the retroperitoneum, doing that percutaneously under fluoroscopic guidance using the imaging assistance of the thiodized oil. It's been retained within those lymph nodes. That can happen, immediately on the same day as the initial procedure. But some of the benefits of thiodized oil that it's retained within those lymph nodes for an extended period of time. So even patients that have had prior imaging, weeks, months prior, there's enough thiodized oil retained in those lymph nodes within the pelvis or upper abdomen to allow us to have direct access with a fine needle transabdominally under fluoroscopic guidance. And additionally, we've been able to do mesenteric lymphangiography as well, similar ultrasound guidance access to the lymph nodes, obtaining secure lymph node access there, and injecting thiodized oil into the mesenteric lymph nodes, which allows us to image a region of the body that really hasn't been seen very much or very often with conventional imaging because it doesn't really have an alternative way of seeing those lymphatic drainage from the intestinal tract. Other adaptations we've done is ways to visualize the liver lymphatic system as well. Usually we start initially with iodinated contrast for those procedures to kind of confirm positioning within the liver lymphatics, as they're very, very fine, small vessels. But once positioned properly, a needle, once it's stable there in those liver lymphatics, you can inject thiodized oil again, which allows imaging for abnormalities that arise from the liver lymphatics, abnormal communication to the mesenteric lymphatics. It also allows for alternative visualization of the upper abdominal lymphatics and even the thoracic duct in patients who have lymphatic abnormalities or disruption of the lymphatics for whatever reason that doesn't permit conventional imaging from the pelvis.
Very good. So can you tell us a few words about what kind of condition we use or we started to treat recently using lymphangiography or and lymphatic interventions? And of course, few words about different types of lymphatic interventions we do.
10, 12 years ago when we were describing this intranodal lymphangiography as opposed to the conventional pedal lymphangiography, at that time we were pretty much treating almost exclusively traumatic chylothoraces. So that's just a condition in which the thoracic duct's been disrupted and there's lymphatic leakage into the chest that contains fat. In those cases, were almost all post-surgical or traumatic in nature. But there were some patients who had unexplained chylothoraces at that time that we were treating, but again, most were traumatic injuries. With kind of the updates of the techniques that we've been doing, We've uncovered some other other pathologies from the lymphatic system. Particularly one that's been very meaningful for us has been plastic bronchitis, which is probably an underappreciated diagnosis. But it's a condition in which chyle or lymph leaks into the airways from abnormal communications between the lymphatic system, particularly the central lymphatic system in either the upper abdomen or the chest into the pulmonary lymphatics, which can be a very debilitating condition in which patients cough up casts of chyle or lymph that can be identified and easily treated with thoracic duct embolization. And we've also been able to find patients who have had lymphatic obstruction that can be treated with relief of that obstruction through either angioplasty, and we've also begun doing surgical reanastomosis of the lymphatic system to veins with our colleagues in surgery to assist with that drainage. And also sometimes lymphatic obstruction or abnormal communications between the mesenteric lymphatics and the retroperitoneum can lead to patients having a condition called protein-losing enteropathy, in which instead of the lymphatics flowing into the retroperitoneum from the mesentery and ultimately into the circulation, there's kind of a retrograde flow and allows leakage of protein-rich fluid into the intestinal lumen, resulting in diarrhea and loss of protein and malnutrition.
Um, can you tell us a few words about interstitial lymphatic embolization? What is that, and how do we use that?
Sure. So that's that is a situation in which patients either have a lymphatic abnormality, lymphangioma, if you would, or even just a guess tangle or nest of abnormal lymphatic vessels that are leaking, and we can access usually those lymphatic masses percutaneously with the guidance of the ethiodized oil. Again, it's retained usually within these masses to some extent for a fairly prolonged period of time, and that allows us to actually directly stick them, and then we can further opacify them with ethiodized oil to confirm the location. And it also lets us visualize the lymphatic system that's connected to these structures. And ultimately, we can embolize through the same needle access that we image with to glue these shut and close them off, or sclerose them to basically permanently obliterate them and seal off the leakage that's occurring.
Very good. Excellent. So what about the um, lymphocell, growing lymphocell, or scrotal lymphorrhea, and the role of lymphatic intervention in these conditions?
For groin lymphorrhea and lymphoceles, we published a couple of years ago some results that demonstrate the ability to actually visualize these leaks. They kind of often occur after either access to arteries or veins within the inguinal region, or more often surgical interventions where either lymph nodes are resected or have been incidentally cut in attempt to access the vasculature in the inguinal region. And in those cases, we've basically been able to find that with visualization through the ethiodized oil, finding these leaks, once they've been localized, we can then use that same access, or maybe even a more proximal access closer to the leak, to then actually glue those lymph nodes shut, as well as the leaking vessel that's supplying that lymphocele. And we've shown that that actually shortened hospital stays, time to actual recovery, and reduced the number of procedures patients needed to resolve the leak.
Excellent. It's great. So what's the most difficult lymphatic condition you usually face in your daily practice?
Well, that would be easy. It's chylocystis. And the reason for that, I think, is that most of these patients have some degree of lymphangiectasia or exuberant amount of lymphatic tissue. I think finding the site of leakage in these patients is extremely challenging. Many of the patients have not had any surgical interventions to explain why they've had the leak. So there's kind of a mixture of problems in the patient. Oftentimes they, again, have exuberant amount of lymphatic tissue, which has become somewhat malformed or irregularly shaped, and prone probably to leakage. A lot of these patients also have some concurrent level of obstruction at some place within the lymphatic system that then has created an increase in pressure in these abdominal lymphatics that then cause them to open and spill fluid into the abdominal cavity. And I think one of the things that makes it even more challenging is sometimes these patients, because of either translocation of fluid across the diaphragm, possibly small defects within the diaphragm, oftentimes when patients will present with a mixed picture where the most noticeable symptom is that they have a chylothorax, but in actuality, the main problem is actually arising, or the point of leakage is arising below the diaphragm, and then leaking into the chest as well. And so, actually finding the site to localize and treat those patients can be very challenging. Oftentimes, the sites can be multifocal, and the success rate is good, but not as good, and not into the near 100% that we have with treating chylothoraces.
Can you, Dr. Nadolski, can you tell us if you can use, or occasionally it happens that ethiodized oil is used as a therapeutic agent?
So the thiodized oil, I don't know if we totally understand why this occurs, but when it's injected into the lymphatic system for leaks that are relatively slow, the thiodized oil oftentimes will I don't know if it either plugs the opening, or just causes enough decrease in the speed of the flow of the lymphatic system that will often cause these leaks to essentially spontaneously resolve. Typically, that's for, again, a small leak, in the chest or in the abdomen. We also have the experience that in children who present with a neonatal chylothorax, a very small quantity of thiodized oil can therapeutically resolve that condition as well, without any need for embolization.
Thank you, Dr. Nadolski, for this amazing discussion. You are truly an expert. And thank for everybody to listening. Please remember to take the post-test and evaluation to receive CME credit, and to tune in for additional episodes within this podcast series. Thank you very much.